The following content is for entertainment and educational purposes only. It does not constitute means for diagnosis, healthcare advice, nor treatment. Make use of a qualified healthcare professional for such purposes.
My name is Dr. Charlene Ortiz. I have a doctorate in clinical psychology and my specialty is forensic psychology. And today you are here for this presentation. You're here for this presentation to learn about what does it look like to have a Ph.D. in clinical psychology. And I hope that this is instructional for you. So the first thing that we're going to cover is my journey, right? What was my journey in order to get a PhD, right? Earning my degree. The second thing we're going to talk about is what does my typical day look like, right? I practice under supervision and I also teach, which is kind of rare. Usually you find one or the other. Either they only teach or they only practice. So you get to see a little treat, right? You get to see a little treat as to how that looks like. And then the last thing that we're going to talk about is two case studies, two of either my former or current patients that have been most difficult. All right, so one of the first things that I want to talk about was my undergraduate formation, right? What did I do as an undergrad? I got an associate's in applied science. What is that? Well, I got an associate that is geared towards research, right? The associates that I got specifically was in intelligence operations because during that time I enlisted in the military. I was an enlisted person in the military. So I got the opportunity to serve, and what did I do? I was intelligence in the Army, right? I was intelligence in the Army for 10 years. And you're thinking, what is intelligence, right? So, whenever you watch a movie, you see a guy with a bunch of panels or briefing a general or briefing a colonel, and say, we're going to be attacked around here. That's what I did. That was my job. My job was very similar to what a CIA agent does, which is gathering intelligence from wherever that may be. Interrogations, terrain analysis, and we don't call them interrogations anymore, we actually call them interviews. I also, it's hard to mind, hard to mind, right? Also, for example, say data analysis or statistical procedures, things like that. My job was to think like the enemy. What would I do to destroy US forces and our coalition, right? Our friends, right? Our allies. So I wouldn't make any decisions, of course. That is the colonel and above, of course, makes the decision. But I inform said colonel, that man or that woman, to make decisions as to what should we do with our mission, right? Is it dangerous? Is it not dangerous? What determination they're going to make. So that was my job in the military. I had 2 deployments during that time. The first deployment, mobilization, I should say, because it's not deployment. I was stationed overseas, right? I was stationed in Puerto Rico. Oh man, what a tragic duty station, huh? I was stationed in Puerto Rico for many years. I do speak Spanish fluently, so yo hablo español. So I was stationed there for a while. And during that time, I served in the reserves in that specific case, because then I earned my bachelor's, right, during that time. During that time, I earned a bachelor's in arts. My bachelor's was in arts, meaning that the focus is not mathematics and it's not research, but rather the general theories and presentations that you find in psychology, right? So that's what I did there. Now, my specialty, or my minor, I should say, for my bachelor's was, guessing what it was? In education, right? I love what I do. This is really exciting for me. I love teaching. I love working with students or interns, whoever wants to learn, I'm going to do it if I can. And if I don't, I'll point you to the right professor. Now, while I was doing my bachelor's, I did have an honors scholarship, so I had to keep a certain GPA. I think it was 380, I want to say, or 385 at the time. I can't remember exactly, but I did have an honors scholarship, so they would pay for my tuition and all my fees. So college became my job, right? So at the time when I was serving in the Army, I also had that honors scholarship, so I did have to keep a pretty high GPA. And afterwards, I got deployed to war during the time when when I had graduated from my bachelor's. That was a big coincidence, right? That was a big coincidence because at around the time that I earned my bachelor's, I was deployed to war. I was deployed to Afghanistan during that time. I got deployed actually by surprise. I was actually not in line to be deployed. But as I've been told, what had occurred is the person who was intelligence in a whole other unit that I had nothing to deal with. The person there attempted to kill the intelligence captain. So he was put on homicide watch and suicide watch. And so Uncle Sam said, let me find someone else that's getting deployed. So I literally got a call at like 9 p.m. saying, I need you to report to this duty station at 7 in the morning. And I'm like, who are you people? I have no idea who you guys are. So I show up, and then you're going to Afghanistan in a couple of weeks. You need a replacement, and you've been selected for deployment. So that's how I got deployed to war. It was very quick. I went with people I didn't know, right? So it wasn't my unit. There, when serving in the military, I had the opportunity, because I was intelligence, I had the great opportunity to travel all around Afghanistan. And it was really good because I got to work with our coalition forces with NATO, right? The North Atlantic Treaty Organization. So think about the UN, right? Something like that. It was really similar. So I got to work with British intelligence. That was super cool. I got to work with the Spanish Army. They're actually really strongly present, at least back then, in certain areas of Afghanistan. And when I say Spanish, I mean Spain. I mean literal Spain. That's what I mean. And I got to work with the Italian intelligence a whole lot. So I got to work with a lot of our allies, right? I also had the opportunity to work with local forces. So for example, I got the opportunity to work with the ANA, and that is the Afghanistan National Army. So I got to work with them and their intelligence. And I also got the chance to work with the Afghan local police. So that was really cool. And what was my job when I was in Afghanistan? Well, like I said, my job was to think, how can I blow you up? How can I hurt you? And gathering that intelligence, I would provide that information to the commander. The commander would decide whether or not it was a safe mission. I was also the first responder for intelligence. So for example, if there was a fire, if there was an attack, everybody would have to take cover, and unfortunately, little old me and the battle captain would have to stay behind because I need to find out, say, for example, through imaging, through sourcing, I have to find out where we're being attacked from right now so that I can relate that intelligence to special forces, and then they could eliminate that threat, right? So that was my job. So before special forces or rangers or things like that could eliminate the threat, I would have to stay behind and see where are we getting shot from, right? So unfortunately, during that time, I did sustain an injury. So unfortunately, because of that injury, I was medically retired from the Army. So afterwards, I started to earn my master's, right? So I was still in the Army, because now we are moving into my post-undergrad. So what did I do? I decided to earn a master's in psychology. My master's in psychology is in applied psychology. And what does that mean? Applied psychology is what I like to call rolling up your sleeves and applying theories of psychology so that you can provide treatment, right? My master's was in science, right? So it was top heavy with statistics and research. And the reason I did that on purpose and decided not to get an MA, a Master in Arts versus an MS, is because I knew that I wanted to get my PhD. PhDs are top heavy with statistics and research, So I was like, okay, I need to prepare myself. Let me get an MS instead of an MA, because I know that an MS is going to qualify me better for my doctorate. So then I earned my doctorate, and I was still in the Army, of course, when I started earning my doctorate. During the time for my master's and my PhD, I did have an honor scholarship. Very painful, but I did. I kept my scholarship the entire time. So I didn't lose my, I only had one B in my PhD, which I didn't care until I started realizing that I was the only B I was getting. I'm like, man, I could have, done better, right? But I only got one B. If you're wondering, it was biopsych. That's right. Let's talk about what did I have to do with this doctorate, right? What did I have to do in order to earn this doctorate? So one of the things that I had to do was a clinical residency. Who here can tell me what a residency is? Either because you're in medical or because you're in psychology. What is a residency? Who can tell me what that is? Yes, ma'am.
Is it like an internship?
It's like an internship, right? It's like an internship. But what happens is you become a resident, you become an intern. And what it is, in a residency, you generally work with faculty and practitioners with clients and or training in a setting in which, for example, in my case, what did I do in my residency? A lot of the things that I did for my residency had an awful lot to do with assessments, because part of a PhD is that I am able, with a PhD, when you get your license and your PhD, you can start doing assessments. What are assessments? Our assessments are tools that we use for diagnosis, right? So for example, intelligence assessments, gauging for a learning disability. Personality assessments, gauging for example, personality disorders. So a huge part of my residency component was to make sure that I was trained to use said assessments. Because normally it does take a long time. It does take a long time to become trained. Usually residencies can be anywhere between a year and 2 years in psychology, right? So that is not including your coursework, okay? So if you're getting a doctorate in psychology, for example, if the curriculum says it's gonna take you 6 years, for example, well, now you have to add another year because you have to do your residency, right? And then let's start adding other years, right? Because it could take you anywhere. I did it full time, 40 hours a week, 9 to 5, your regular schedule. So it took me a year, right? If you do it full time. If you do it part time, it can take you maybe 2 years, maybe 2.5. So if you do it part time, I did everything full time, like I mentioned, right? So I went straight through that. I know a lot of you, I see a lot of eyes like, what? So make sure that you keep that question, right? Because we're going to have a Q&A at the end. Now, what else did I have to do for my PhD? I also have to do a practicum. A practicum. What is a practicum? As the term suggests, a practicum is where you get to practice. So I want you to think about a practicum as you're riding a bicycle with training wheels, right? That's what a practicum is. You're practicing, but you are heavily supervised. I know, #relatable, right? So let's talk about practicum. You are an intern. You can also be referred to as a resident, but generally the term that they use is intern. And what you do, you will have your own patients. You will have your own clients, but you will be heavily supervised. So in some occasions, right? In some occasions, your supervisor, right? During residency, during practicum, and during internship, you have at least one supervisor. And who is this person? This person holds a license in your field, and basically they're your liability, right? They make sure that you're doing what you're supposed to do, that you're not engaging in malpractice, that you're not harming the client, that you're not traumatizing the client, right? That happens a whole lot, especially with new interns, because you'll have a patient that is revealing really intimate stuff or really difficult stuff, and your first reaction is going, what did he just say, right? So that person is there to gauge you, right, to correct you. So there's, for practicum, you get to have your own clients, and you're wondering, where did I do my practicum? I did my practicum here at the counseling center of our university. So my patients were people like you guys, right? So I treated students, but I wasn't faculty then, right? I wasn't faculty then, I was a doctoral intern. It was super cool because I was the only doctoral one. So I got my own office and it was like so cool. They treated me like a whole doctor already. I'm like, oh man, what? This is cool, right? So I got to treat outpatients, right? That's what I did for my practicum. We have a counselor. So I got to practice under supervision, right? A practicum, and you're wondering, how many hours do I have to do of that, right? It depends on your state. And their requirements at the time back then was that I had to do 1,000 hours for practicum, right? 1,000 hours. That's either in front of a patient, doing therapy, in front of a patient, doing assessments, or doing research, or doing supervision. I have to be doing something, and that's all quantified, right? You actually, your supervisor signs off on your hours. So afterwards, I also worked in my internship, right? And what is internship? Now you're not using the training wheels anymore, right? You're not using your training wheels. You're kind of riding that bicycle all on your own, right? You're still supervised, right? Because I have to report back to my supervisor what's going on. And you're still under supervision. However, it's less supervised because you have already about anywhere between 300 and 1,000 hours under your belt. So it is expected that now that you are an intern, that you can perform with supervision, but not as heavy of supervision. And you're asking, how many hours does it take? Again, it depends on your state. I had to do 2,000 hours for my internship. Some of you who are in medical careers are like, what? All right. 2,000 hours, 2,000 hours. So a total of 3,000 hours plus 1 year of a clinical residency. So that was my experience. And then, hooray, I graduated, right? I graduated. So let's talk about how I am starting out, right? So I am still considered an early career practitioner, right? I'm considered an early career. I earned my Ph.D. in clinical psychology. And I earned my Ph.D. 2020, so I'm considered a fresh doctor, straight out of the oven, right? So I'm still hot. I still care. That's what I'm trying to say. I still care. It's like, oh man, he's struggling, you know? Like I still care, right? Or I'm like, yeah, I want to teach, you know? I still care. Is what I'm trying to say. What did I have to do? It was very difficult because what happened in 2020? COVID. And I was so upset about that whole situation because there was a high need and there still is a high need for practitioners. So it was kind of difficult. What do I do now, right? So right now, what I am doing, I got a job, finally, right? I got a job. And I started working under supervision. Now, before that, before I finished my doctorate, I worked at a maximum security prison. So what did I do there? I worked mental health in the maximum security prison. So what did I do? I dealt with homicidal and suicidal inmates, people who are actively suicidal and homicidal, meaning that they could quite literally be found hanging from their cells. For example, they just stabbed an officer, they just stabbed a nurse, they just stabbed someone and tried to strangle someone. What else did I do? Well, I did my internship in that same institution, right? I did my internship in the same maximum security prison. And what did I do there for internship? I did sex offender therapy in prison. I was the person they would talk to about their crimes and sex offenses to decrease the chances of recidivism, meaning that if they were to be released, because of parole or because they finished their sentence, reducing the chances that they will reoffend once again. It was a requirement for a lot of them to do that in order for them to even be considered for parole. So they were stuck with me. They had to do sex offender therapy with me. I saw absolutely everything, unfortunately, and this is a trigger warning, right? This is a trigger warning. I dealt with a wide variety of individuals, people who are there for voyeurism, assault, rape, sodomy, which is a legal term, by the way, it's not a mental health term. Sodomy is a legal term. And I dealt with people who engaged in pedophilia quite a lot. I would like to estimate 40 to 60% of all of the gentlemen that I had the opportunity to work with were there because of pedophilia. In the state of Alabama, pedophilia is classified as having sex with a person 19 years or younger, right? Not 18, 19 in Alabama is still considered pedophilia. if you have sex with an individual who is 18. So I dealt an awful lot with that. And I also did anger management in the prison. I also did conflict resolution, also managing depression in prison, right? And a lot of intelligence assessment, right? In our state, and it's a federal requirement that we do intelligence assessment. And why is that? Well, because we need to make sure that we don't have an inmate who has a learning disability and needs any reasonable accommodations while they are in prison. So that was also something that I did. Let's talk about what does it look like for me to have my typical days, right? My typical days. I start my day off by seeing patients. I see patients in the morning, right? Before I come to class. I see patients in the morning. Usually, I'm one of the few providers that provide services in Spanish in the region. My understanding, I'm the only one in North Alabama. So I do have a lot of clientele that only speak Spanish, or that they do speak English just fine, but they prefer to do it in Spanish. And then one of the things that I do, usually when I get there, I usually already have messages. I usually already have to call someone or reschedule someone, or maybe someone's in a crisis. So because we don't handle crises where I work, that person will be a referral, right? But that person will be referred out because we don't deal with acute crises where I work under supervision. Now, after I see my patients, I teach, right? One of the classes that I teach here, and most of you may be from that class, is Intro to Psychology, right? General psychology. So I teach very introductory courses. So for example, your 101s and your 102s. Intro to Psychology is a very typical coursework. It's usually one of the most popular courses. So I have about 200 students in my intro courses. In my 101, I have like both of my 101s, and then I have about 70 in my 102, and then for my research class, which is a more advanced class, I only have 20. Like about 20 or 15 or 20 people in my research class, right? So I do teach research, and you're wondering, why do we have to know about research in psychology? Well, we have to teach about research because I would not be able to practice. I wouldn't be able to practice if we are not able to do research. What we do is scientific. We don't do guesswork. I'm not over here throwing things at the client, hoping that something's going to work, right? Because that's what we call malpractice, right? So everything we do is based on research. So I do teach the research class. There is a research lab component. And afterwards, throughout my day, you can see that I'm a very busy gal, right? I also work with the research lab as well. So one of the things that we do is whatever we practice in class, we try to do a hands-on, right? So it's really difficult to see correlations if you actually don't run correlations and statistics yourself. Or it's really difficult to see an experiment or a content analysis and things of that nature if you don't actually have a lab component. So that's one of the other things that I do, right? I work with the lab component. So what you're seeing here is a typical program that we use in social sciences, which is SPSS. It's a software that we use to conduct statistical analysis in social sciences, so psychology, social work, and other related fields and things of that nature. And what do I do when lab is over? I go back and see patients again. I go back to the office. So generally, again, I do see clients that are already scheduled. It's really rare that I have someone who is acute, but I do get people who are acute and people who need immediate care. So that's another thing that I do. I talk to people who are in need of chronic care, usually not necessarily acute, but I can work with acute people as well. Now, you're thinking, right, who do I work with? Other fields that I tend to work with. Most of the time, I get to work with just your regular general MD, right? I work with them quite extensively. I get a lot of referrals, usually from pediatrics, right? So I do get either from general MDs or pediatricians, right? So I do get that a whole lot. Or kids who were in a crisis and they were inpatient, right? So they were involuntarily committed, and now that they're being released, they need to talk to me. right? Because they dealt with the acute care, and now we're dealing with the chronic care. So kids who've been released. I deal also with social workers. It's my least favorite thing to do, and why is that? Generally, if I'm talking to a social worker, I'm dealing with a child that's being abused, right? So generally, that's why if I know I need to talk to a social worker, generally I'm either dealing with a child that's being abused in any way, sexually or neglect, it's not being fed, or it's being assaulted, or I'm dealing with an elderly person that's being neglected or sexually assaulted or things like that. So they are probably my least likely. I love them to death, but generally if I get to work with them, it means that something is going on. I work an awful lot with nurse practitioners as well. So every now and then, one of our clients would say, hey, I want medication. Of course, I can't prescribe medication because I have a Ph.D., not an M.D. You need to be a medical provider in order to provide medication. So more often than not, they will like, hey, I want you to talk to my nurse practitioner, or I want you to talk to my psychiatrist so that you can tell him or her what's going on. So I do correspond with them with the permission of the client, and vice versa. Sometimes the nurse practitioner or the psychiatrist sends them to me, right? Because they don't need medical care, they need psychological care, right? So sometimes they'll send them to me. Every now and then I get to work with speech pathologists, right? So every now and then I do have the opportunity to have a child that, for example, has some concerns with their speech. So every now and then I do get to talk to them. We get to talk to them about that situation. So I do have the opportunity to talk to them as a referral. Let's talk about our case study. We're going to call him male, right? We're going to call him male A. What can I tell you about male A? Male A is in his 30s. He is white and he is married. Now, his mother wanted him to start therapy because within a couple of months of the marriage, he told his spouse, he said, I can't stay married anymore. I am gay. I can't stay married to you, right? So his mother decided, hey, go talk to this lady, right, to manage that, right? So it turns out he really doesn't have any issues with his sexual orientation. He's completely content with him being gay. He doesn't have any concerns. He is still married, however. He does have a child, right? He does have a child with his spouse, so he's still married. But he has decided to stay married, but separate, right? They don't live together. They don't live in the same place. They don't live together, but they decided, you know what? I'm going to stay married because of our child. But he decided to not have a romantic relationship anymore with his spouse. And you're thinking, well, what's the problem then? You know, they have a good arrangement, whatever works for them for the marriage, and he's okay with his sexual orientation. I'm seeing him because his brother one day let him know that their mom had sexually assaulted him his entire life. That's why I'm seeing him. Mom thinks he's seeing me because of sexual orientation, that he's struggling with being gay and married and all that good stuff. But I'm really seeing him because his brother confided in him that mom had molested him and sexually assaulted him and sodomized him all the way up until he was 16 or 17. So she would force her son to have sex with her. That's why I'm seeing this client, right? That's why I'm seeing this client, because he feels conflicted. He is the oldest son, right? So he thinks that it's his fault that he didn't see these things while they were kids, right? So he blames himself. He has a lot of guilt and a lot of shame. He says, you know, I'm the man of the house. I'm the oldest one. I should have protected my brother. That's why I see him. That's why I see him. Something about that is that I had another client and I started seeing the other client. And once I started seeing this client, I didn't know nor realize that that client was this client's mom. So I'm seeing both, is what I'm trying to say. Without my knowledge, I had no idea. So now I'm seeing both. But of course, that's not something I can bring up in session, because why? Because I got it from an external source and they're both entitled to confidentiality, so I can't bring that up. I can't bring that up to session. What is my advice? What is my advice to you, whether you're in the medical field or the psychology field? My advice is remain in your field. Nobody likes to be told something when they don't know what they're talking about, right? So for example, I'm not going to tell a pediatrician, you need to prescribe them with this, right? So I wouldn't expect that pediatrician to come to me and, hey, you need to treat him for this, right? Stay within the limits of your field. Not only is that the ethical thing to do, that is the legal thing to do, to stay within the limits of your scope. Okay, that is the legal thing to do. The other thing is recognize the limits of your practice. Don't think that because you are a doctor or because you have a master's that you can handle everything. That is not true. So for example, normally I don't treat very young children because that is the limit of my practice. I am not trained to deal with toddlers, right? Our youngest patient right now is 18 months old. Our oldest is 82. I'm not trained to work with really young children, however my clinical supervisor is. So it's really important, whether you're medical or in psychology, to know this is it. This is what I can do because of my training and because of my education, okay? And the last piece of advice that I'm going to give you, especially once you start building up that education and you get your master's and you get your doctorate, remain teachable. I don't know everything, right? That's why I have a supervisor. Sometimes in class, for example, maybe a student has a question that I can't answer, and that's okay. Stay within that limit. Remain teachable. Just because you have your MD, just because you have your doctorate in dentistry, because you have your doctorate in medicine, because you have your Ph.D., your PhD, remain teachable. You don't know everything, for one thing. And number two, psychology is a science, which means it gets revised. So whatever you were taught a couple years ago, maybe we have more research now that suggests that that's not the best approach. Questions?
So I know you can't bring in your own personal as a therapist versus as a normal human. Would you believe that she's possessed? You once said that their crisis is your crisis.
Right.
Would you believe that they are possessed or are they?
Now that would be, and I'll answer that with a question. I know that normally that's not how you should do it, but I have to ask, is my religious belief, when I'm using it in therapy, is it going to help her or is it going to help me? If the answer is, it's going to help me in managing my reactions to this demon religiously, then the answer is no. You have to learn how to compartmentalize and divorce yourself. But it's not about me, is it? It's about the client. So you have to learn to training to compartmentalize and see, am I wearing my clinician hat? Am I wearing my medical hat? Am I wearing my therapist hat? Or am I wearing my good old Shar hat? But you have to divorce yourself from that situation. Otherwise, you're going to get very hurt in therapy. Because now, instead of empathy, you have sympathy. And that's what you want to avoid. I cannot get possessed with him. I have to recognize that this is a hallucination and that he needs my help, right? If later on I want to go to church or temple or mosque or whatever and that's on me, right? But in that moment, it's not about me. I saw a question here. Yes, ma'am.
You mentioned that you've been assaulted by patients. So when you're assaulted by a patient, are you not allowed to see that patient? Do you get like a choice of like, I would like to still?
Do I get a choice in saying, you know what, Billy over here beat me up? I'm not seeing him anymore. I'm not seeing her. Who says yes? I'd be like, bye. I don't want to see you. Bit me in the arm, which did happen. Bit me right here. I got beat up by an 8-year-old.
Reverse question. Why can't you just beat Billy back up? For
the same reason I can't beat you guys up. I can't be like, you said what? In class, and you go catch that hand right here. For the same reason. I need to learn that it's not about him biting me in the arm. The answer to that question, who thinks I can say, bye, Billy, I'm not seeing you anymore? Who says no? I can't ask for, I'm like, no, I can't see him. Who says, no, you have to keep seeing him? The answer is I have to keep seeing him. The answer is yes, I have to keep seeing him. But now I talk to mom because I don't like getting beat up. He broke my Mac, y'all. Man, he broke my Mac. My Mac doesn't really work because he grabbed my Mac and tossed it, and then he bit me in the arm. And I'm like, I got home and I'm like, I got beat by an eagle.
Are you allowed to take revisions though? Like,
Yes.
your MacBook?
Yes. So now there is no Mac when he's around. There's no Mac. Any questions here? Yes, ma'am.
Sorry, a question about that assessment. Is that, you can't stop seeing them as personal thing, like every therapist? No.
That is malpractice. That is patient abandonment. It is considered a form of malpractice, just like in medical. Yes.
So if you are getting beat up by a patient, and you're only allowed to like walk, like, would you have to wait until they get done, or is somebody gonna come save you, or?
Generally, everybody else can hear it. So usually there's gonna be a therapist just wobbling around, like saying, "Hey, you all right there, champ?" You know. Usually, what usually tends to happen, depending on your organization, we have little buttons. We have little crisis buttons that you guys can't see. So I'm with the patient, and if the patient's like over here, like, "Hey, I'm gonna stab you in the neck," I'm just gonna press that button real quick, right? Whereas where I practice now, there's none of that. It's not like that I've fallen, I can't get up button. So it's kind of like that, right? So you press it and it sends a phone call and it sends a text message and it sends an email to everybody. So it interrupts everybody. So when you press that button, it means everybody has to come to a halt and go there for whatever reason. I haven't had a need to use it though, so that was nice. And none of you guys wanted to stab me when I was your therapist at the counseling center. Another question here. Yes, sir.
So for patients like Ph.D, like with the girl like your sister, can you tell the sister, like you tell anyone if life's in danger?
My job is to reduce the chances that that's going to happen. So I have to do stabilization, symptom stabilization. I also have to do an assessment before I do that, assess their level of risk. What do I look for, right? Homicide or suicide? Intent, plan, means, and opportunity. If I can't deter you from one of these four, I would have to break confidentiality because now your life is at danger. Then I would have to break confidentiality. I'm the person that has to reduce the chances. However, am I responsible? No, I am not responsible because murder and suicide is an individual decision, right? My job is to reduce the chances. But I wouldn't be responsible if I followed ethically what I had to do. So the answer is no. Yes.
So then it sounds like those four things were in place. So how did you reduce, what did you reduce? How did you reduce it from happening or know that it was going to not happen?
Well, I don't know it's not going to happen, right? Remember, but we reduce the chances.
Right.
So one of the first things that I like asking suicidal, I do have a lot of suicidal clients though. I do. I have a lot. I actually just dealt with one like an hour and a half ago. She actually did successfully cut herself a couple months ago, or maybe more than a couple. She bled out, she passed out, lost consciousness. That's considered a serious suicide attempt. In his case, one of the first questions, whether male, female, suicide, homicide, I like to ask what stopped you. You could have done it. Why didn't you do it? And usually that is what we call mitigating factors or reduction. One of the reasons that she didn't do it was, quote, because God can fight these demons. And I talked to God and God told me not to kill my sister. Whatever it is that worked for that person, I don't care how out there it may sound. If it worked for them not killing themselves, or if it worked for them for not committing suicide, I'll take it. I had a client the other day. Unfortunately, he's a suicidal individual, and his rationale for not committing suicide is because he doesn't want to leave his dogs alone when he dies. I don't care what it is. If it's the next football game, if that's what's keeping you around, I'll take it. Whatever it is, whatever, small or large. So with him, he had morality. He had a low concept of morality, and for those of you who are taking 101, that might be something we can cover during the semester, the morality development. He did have a low level, I'll take it, more than no morality, and fear of being apprehended. Now, on the other hand, we're doing better. We still have God, so we have religious beliefs. We have apprehension of being punished, and now we have, because I want to be a good girl. I don't want people to think I'm a bad girl if I kill my sister. And the other was The other mitigating factor is therapeutic relationship. So she said, I don't want to disappoint you because you helped me a lot. So therapeutic relationship is another deterrent for homicide. Any questions here? Yes, ma'am.
Okay, so
She wrote them down. She's got receipts. Look at
I only have one.
that. She wrote them down,
I
guys.
only have one. So why didn't the pediatrician send her straight to the acute facility?
Why? Then my question is why? Why would she send her?
Because so in the past, not me, but like my little sister, she had the suicidal tendencies, like the thoughts,
Right.
and she was straight to the mental facility.
It
So
depends.
why didn't she has a plan with me?
The pediatrician didn't know that. I knew that. The pediatrician had no knowledge.
She just knew that.
She was like, here, Dr. Charlene Ortiz, here you go talk to her. Bye. I don't want you.
About the demons.
I'm sorry?
She just knew about the demons.
Yeah, because she got possessed in session.
Oh, okay.
That was it.
Yeah, okay.
She didn't know about all this that I just told you guys, all this tea. She didn't know that. I know that because I'm her therapist. I saw another question here. Yes.
So how has your experience in the Army affected your faith in clinical or private practice?
Nothing really bothers me. There's nothing really you can say or do that I'm gonna be like, what? Like I'm gonna be like, oh, it's Wednesday. Let me go watch some Dragon Ball or something. Like it's just, like it's just Wednesday, The Army, right? It helped me, but it has also been difficult because when you're in the Army, even if you never go to war, you have this behavior of like toughing it out, suck it up. Pain is weakness leaving the body, that whole mentality in law enforcement. And Dr. Seaman was actually really good at bringing that up because I remember when he was interviewing me to be his intern, he said, you've been in the Army, right? And you deal with a lot of stuff there. What makes me, and that was to be hired for the counseling center here. Usually the presenting issues that we have in a college setting tend to be less severe. They are usually adjustment disorders, right? Like, I have a hard time getting used to college. I'm failing my class. My boyfriend left me, that kind of stuff. So adjusting to things. So they're usually less severe. They will refer you out if you have schizophrenia and you're like, go be over here getting possessed at the counseling center. You're like, haha, get it off the show because you're not staying here, right? They don't deal with that. They only deal with short term. And the question that he asked me was, how do I know you're going to have empathy for these patients? Because I'm going to have a patient, which has happened. I would work at a counseling center and I'll have a patient. I'm suicidal. I want to kill myself. Okay. What's going on? I got to be in my exam. Look at him. He's like, what? But remember that every crisis is a crisis. So for him, for someone who's been in service, you see so much stuff. Like I saw people burned down, blown up. It's horrible, right? But yeah, that's true. I've been told human flesh tastes like pork. I don't know if it's true. I haven't tried it. Don't recommend it. They don't sell it in Whole Foods, so don't try it. So that was his question, and that's a valid question, because sometimes it is a little hard to develop empathy, right? Like I have someone, for example, girl B over here hallucinating, wanting to commit homicide. This is like super severe. But then I have another student who's like, I'm going to kill my professor. Why? Oh, because I have a B in the class, right? They're both as serious, right? They're both important. And so whenever you deal with personal experiences like the Army, for example, that can make it difficult to have empathy. So something I have to teach myself often, crisis is relative. Crisis looks relative. For you, getting a B was a reason for suicide, just like the demons for girl A are reasons for homicide. So a question here. Yes.
I was going to ask, I know you said you can only defend yourself. Is there no kind of like restraint training or anything like that?
Yes. Yes. Many companies teach you as to how to restrain and block accordingly, right? So that does happen, especially in high-risk facilities. For example, if you work with a lot of autistic children. Yes, some places do. It's not a requirement. It is a requirement, I think, if you receive funding. I think it is, but don't quote me on that.
So like some therapists disorders.
Yes. Good question. So Bailey beats me up. I can't kick him out of session, right? What would be a reason why I wouldn't see a client? And that goes back to one of the slides that I was talking about. You have to remain in the limit of your scope. That is a good reason to deny treatment. So for example, right? So
So if it's someone you're familiar with, that you can't say.
not necessarily, and I can answer that question. So I have to stay in the limits of my scope. I've never been trained, nor in residency, practicum, or internship, nor in any of my education to work with toddlers. So whenever we get a referral, like, hey, Dr. Shaw, you're gonna have this 2-year-old, I can't. I can refuse that because I am not legally nor ethically qualified to treat this person. Or for example, a disorder that I have no idea how to treat. For example, I'm not too familiar with autism. So if I have an autistic, I could treat them. But if I know that there is a better person to treat him or her, the ethical and legal thing to do would be to refer them to that person. That's when you can refuse, when it is outside of your scope.
Sorry, so you need that in the middle of that, like, do you have to, is that opportunity for like first getting?
Yes, first, when you're very first getting acquainted with them, you can't be seeing them for 6 months and be like, Billy, I don't want to see you. Patient abandonment. And I'll give you I'll give you you know what's so funny? I had an intern with me. She's over here learning from me, and I'm over here, keep it cool, keep it cool, keep it cool. There's an intern here. You're teaching, do not flip, right? Yeah.
Do you think if the intern wasn't present, you would have flipped?
No, absolutely not. I am a professional man. For those of you who are medical or not my student, you're like, who is this lady? Where did they hire her from, right? Where'd she come from? What? So, apparently, it's like, never mind, I'm gonna keep that to myself. I recently had a conversation, but anyway.
So technically, you wouldn't be sponsoring your patient.
I wouldn't have this.
Have you ever experienced that yet?
What does corruption mean?
Other patient.
Okay.
Have you ever had a patient thus far that has not been treated properly and or been mistreated or they were quote unquote thrown under the rug?
Luckily, most of the time when I see someone, they've been treated, they've been referred correctly. So I haven't had. I do see, however, sometimes misdiagnosis. For example, oh, this kid has ADHD. It's like, no, he doesn't. He's been traumatized because ADHD and trauma in children looks exactly the same. But a physician is not trained, and ND is not trained to detect the differences. So for a medical doctor, it looks like ADHD, but in reality, this kid was ill when he was born.
Like that. When she first expressed that she had it that she wanted to murder her sister, and she expressed that she contained all 4 of those variables, why weren't the parents notified first and then you tried to reduce the instances?
Patient is above the age of 14, and in the state of Alabama, you are considered a legal adult for medical and psychological help at the age of 14. I cannot break confidentiality and tell mom that because the patient was 14. Two questions, sir.
Go back to the homicide and suicide risk, like infection or whatever. What if those mitigating factors, like the dogs, for example, like what would be your course of action for that? Like how would you like go with that if those mitigating factors
Disappear?
disappear?
Find other ones. Whatever it is, you have a session with me next week. I don't care what it is. Let's find another one. If that doesn't work, plants, reducing the plant. How do you want to kill yourself? I have a Ruger LPC2. I'm gonna shoot myself. Okay, I need to remove this LPC from me. Can I talk to your spouse? Just to ask them to remove that gun. Can you talk to your spouse right now and tell them to hide that gun? I have to reduce one of these. One of these has to come down in order to reduce the chances for suicide. Can you hand this gun to your friend who lives in like, I don't know, Decatur? So it's kind of hard for you to go back to Decatur a little bit, right? Things like that. Opportunity. When do you want to kill yourself? I want to kill myself Friday because I know my wife's not going to be there. Okay. We need to do something Friday. So I can see you Friday, right? Now I'm going to see you every Friday instead of every Tuesday, for example. I have to do something to reduce intent plans means an opportunity for suicide. So, if I cannot, the next thing that I do, that's just my prerogative, is asking the person to admit themselves voluntarily, for them to actually go to the hospital on their own accord. If that doesn't happen, then I have to break confidentiality, because you are in a crisis and you have the psychological capacity to make decisions for yourself. I have to be the authority to make that decision for you.
That's it, beautiful people? Well, I hope you enjoyed